Thank you.
Thank you. Good afternoon, everybody. I'd like to thank the organizing committee, Dr. Ramaiah and Dr. Thorpe, for the kind invitation. I'll be talking about the PE guidelines, PERT, and finally, my personal opinion. I'm going to tell you at the beginning that my personal opinion is going to be off-label. It's going to be different from current recommendations, but however, you will recognize that it's going to be logical and at least would be a pause for thought and reflection. I have no disclosures. PERT stands for pulmonary embolism, pulmonary embolism. It was a brainchild of a response team, which was the brainchild of Dr. Rosenfield from Mass General. It was developed in 2012, and the consortium was formed in 2015. It was a very successful program, and it had developed because of the discrepancies and variations in the treatment of PE. And of course, when you look at this, you know we can do better than the conventional guidelines, which has been advocating anticoagulation alone for the majority of patients. Now, the traditional approach is not enough. We can do better. And because there are lingering symptoms with the majority of the patients who present to the hospital, and we have witnessed robust improvement with thrombolysis. Now, the dreaded complication of thrombolysis has been intracerebral hemorrhage. If you look at the overall data, it has been between 0.7 to 6.4%. And if you look for PE studies, it has been around 2 to 3%. So you say thrombolysis, dangerous, let's deal with something else. Again, back to PERT, it has been very successful. It should be the poster child of any campaign that you would like to launch. And that's because of the proven record of the organizers, outstanding researchers, top-grade institutions, and the unanimous support of the industry as they wanted them to use their products. And the other hospitals, they wanted to follow the leaders and be known for their status in their community. So it was an outstanding success story. Immediately, major institutions had the PERT in them, and their leaders were the organizers of the major societies like VIVA, Society for Thrombosis, Hemostasis, American Thoracic Society, etc. In 2015, when it came out, major institutions were already involved. Now, there is yet one state to be found that doesn't have this program. And they use a combination of several modalities and specialties in their program. It's 24/7, and as you can see from this diagram from Mass General, there has been a continuous use of advanced therapies with the use of PERT. Now, this is a simplified version of a simplified version of the classification of PE: high risk, intermediate risk, and low risk. And then intermediate risk is low risk and high risk. Now, this is the easiest way to follow. But then you have this one that you need a PhD to follow, and this is the PERT algorithm. And for this reason came the artificial intelligence, or AI, and they say, well, we need a better system to communicate. There were two companies, there are several companies, but two of them, ADOC and Viz.ai, has been instrumental in this. So they have it in their cell phones, the PERT team. The system would recognize what is required to have advanced therapy. It sends the picture to those involved, and then there is a communication between the individuals, and a decision is made. The system also tells you the RV-LV ratio and what is the recommendation in this setting. And it has been taken, it has become viral, and these systems are expanding. And there is also a lot of information about PERT and this system. Words like revolutionizing, enhanced therapy, paradigm shift. It comes every day in different societies, and there's not a meeting that doesn't have this. The role, I would like to summarize it. I won't go to the specific data, but they have data for all of these. So AI increases awareness, detection and diagnosis, rapid notification, risk stratification, determination of optimal therapy, monitoring progress, long-term consequences, and expansion of evidence base. So this is the ultimate result of using this system, and they conclude that integration of AI in the realm of PE is very effective. Now, going to the guidelines come from, there are several societies which have guidelines, but this is from the American College of Chest Physicians. It came out initially as AT9, antithrombotic therapy version 9, published in 2012, with the first update in 2016 and the second in 2021. Basically, the highlights are as follows. In patients with subsegmental pulmonary embolism, you don't need to treat them. Those who have incidental finding of asymptomatic PE, they should be treated the same way. Most patients with PE not associated with hypotension, we recommend against thrombolytic therapy. This is the problem that I have with this system. I'll get to it shortly. Those who deteriorate, you can give TPA, and those who are low risk can be treated at home, and those who deteriorate further are not candidates for thrombolysis, they can get catheter-based intervention. Also, low-risk PE, they can do it at home, and for those which have, for maintenance treatment, factor 10A inhibitors are preferred over warfarin. And in a setting of cancer, initially it used to be Lovenox, but now these take precedence, and now you will target it to a specific number of 2.5 rather than 2 to 3. So in my opinion, we can do much better than what I've talked about already. We have to keep it simple. Now, this is a very important slide because I would like to submit to you that all flow is into the lungs. If you give TPA through a capillary versus central vein, it converges in the lungs. And the lungs receive this through the vasculature, not the cavity. Heart receives 100% of the cardiac output, but it's through the cavity. It only receives 5% of the cardiac output in its circulation. So the standard TPA dose, which is 100 milligrams, is for an organ which receives 5% of the cardiac output. If you extrapolate, an organ which receives 100% of the cardiac output only requires 5 milligrams of TPA. Now, for the stroke, similar dose, 90 milligrams for 15% of the cardiac output. That's why lungs are exquisitely sensitive. And I would like to submit to you that TPA at low dose, meaning 50 milligrams or less, is a distinct entity that's standard TPA, which is associated with complications. So the rule of thumb is if the patient can get an oral anticoagulant, he can receive safe dose thrombolysis. You have complications with standard treatment. Now, this is our publications on the safety of low dose and the efficacy on safe dose thrombolysis. There are at least 100 times more. So in the sphere of chaos, which I call it, yes, you need the PERT. But Sharifi's algorithm is this. Let's go back to that one. Okay. This is my algorithm. If the patient has symptoms and at least moderate thrombus, they should receive low-dose thrombolysis. Now, let's say a patient comes with PE. If they are stable, they get 25 milligrams of TPA. You don't bolus them with heparin. Maintenance dose is continued for 24 hours, and then you switch them to a direct oral anticoagulant at the maintenance dose. For unstable patients, you give 50 milligrams, never 100 milligrams as recommended. If they are crashing, 50 milligrams in 1 minute, and if there's no improvement, you connect them to the ECMO, and that's it. You don't need more algorithms here. True contraindications, large intracerebral hemorrhage and brain metastasis. And so there has to be a paradigm shift in considering anticoagulation, antithrombotic therapy first rather than anticoagulation first. So in the sphere of chaos, PERT is necessary. But in the sphere of simplicity, PERT is an impertinent approach with perturbation of sound logic pertaining to PE treatment. So I'm going to also make a prediction that all these studies that you will see will have positive results. Anything which makes a simple hole in the amount of thrombus will improve the outcome, especially the RV-LV ratio. And with that, I'd like to quote from Newton, who says, "Truth is ever to be found in the simplicity and not in the multiplicity and confusion of things." And PE can be simplified. Thank you. Yeah.